So thank you to the MMRF and to Dr. Bergsegel for the invitation to speak here. I admit Dr. Bergsegel kind of humbled me because my mother is a doctor too, but I can tell you when I was growing up, I do not recall any scientific conversations. I recall a lot of conversations about my need for Gloria Vanderbilt genes, but so I think he really was an overachiever from a young age. So what I'm going to talk about is stem cell transplant. And as some of you know, City of Hope is sort of one of the largest transplant centers. And in fact, that's why I went to City of Hope to do a transplant fellowship. And then basically, once you live in California, it's very hard to leave. So I stayed there and watched the program grow, and the field in terms of transplant for myeloma really changed and expand. So it's been a really exciting time. But just basic terminology, obviously some of you have had transplant, some of you are new to it. So, just stem cell and cell. What is a stem cell? So they are cells that can reproduce themselves, so self-replicate, which is incredibly unique. The other thing they can do is differentiate into other cells. Now, having said this, it's also important to know when we talk about stem cells, we talk about there's many different kinds of stem cells. So, frankly, I live in Newport Beach, which if you may not know, we have literally on staff at our hospital 200 plastic surgeons, maybe 10 oncologists. So, when we talk about stem cells in Newport Beach, we talk about, these kind of stem cells. But for the purposes of today, we're going to be talking about hematopoietic or blood stem cells. And I'll show you a little bit about the process of harvesting those cells, how we engraft them back into patients, and how those cells then differentiate into the cells that you need, the white cells that fight infection, the red cells that carry oxygen, and the platelets that help your blood clot. Now, so there are two kinds of stem cell transplant, right? But they are both predicated on the initial basic same theory that high-dose chemotherapy and or radiation eliminates the underlying malignant disease, a malignant clone in the body. And then we engraft stem cells. So autologous is using patients' own stem cells. And in that case, really the cure is, or at least control of the disease, I should say, is from the high-dose chemotherapy. Allogeneic transplant's a little bit different. It's using stem cells from a donor. And so it's a much more intensive undertaking because you also need immunosuppressive therapy to prevent some certain complications, which I'll address briefly. And the cure in this case comes from both the intensive chemo or radiation, but also from that new immune system. And what you'll hear more about later today in terms of the myeloma talks is really the fact that you may not need to do allotransplant to get immune effects. And in fact, now there are lots of other exciting other options with immunotherapy that may be able to get this same benefit without some of these complications that we see in the setting of allotransplant. So this, as I said, is the rationale for high-dose therapy, and I put this one in just so I could look smart for Dr. Bergsegel, but really, what I could have shown you a picture of my shoe closet, because it's the same idea that more is better. And so, I guess this pointer doesn't show it, but basically, as Dr. Bergsegel alluded to with melphalan, giving one big dose of melphalan seems to be the best way to kill myeloma cells. So and it's not just melphalan, it's other chemotherapy too. So as you give more chemotherapy, you kill more cancer cells. But at some point, you are going to end up causing toxicity to the other organs in your body, right? So your liver especially, that's where you detoxify a lot of chemotherapy. If you give a lot of radiation, your lungs will start to suffer some of the consequences. So, it's sort of like skiing, right? The higher you go, the more risk you're going to take. And so if you get to that far end of the curve on the right-hand side of the screen, that's kind of where the leukemia doctors hang out. And some of that is because in the setting of leukemia, there's not as many choices in terms of treatment either before or after the transplant. So you really are counting on the transplant to do most of your work. On the other hand, in myeloma, myeloma doctors are a little bit more cautious. We're kind of on the lower end there because we have a lot of good drugs before the transplant to reduce the amount of myeloma. And as I'll touch upon, and you'll hear from other speakers really, we have treatments, maintenance therapy after the transplant also to continue to control the disease. So you've seen this slide, I'm sure, many, many times, and Dr. Loniel was kind enough to lend it to me in regards to why we do transplant. And so I'm not going to spend too much time, but just to say, remember that term MRD, right? Because that's what we're going to get back to when I show you some of the transplant studies. And really just the idea is obviously trying to reduce the disease to the lowest possible amount. And that number, how low can you go, is getting lower and lower, both in terms of our ability to reach it, but also our ability in terms of different techniques to detect small amounts of myeloma in the body. So this is Dr. Donald Thomas, who actually was sort of the grandfather of stem cell transplant. He, over 40 years ago, demonstrated that you could engraft stem cells that would then differentiate and grow in a patient. And this is him, accepting the Nobel Prize. And it's an amazing in 40 years how much the field has really changed. And some of my colleagues who remain nameless have actually been at City of Hope for 40 years. And they tell me stories about when this field started, and they did very much work closely with Dr. Thomas, in terms of starting the transplant program, and it's a different world back then. They would admit the patients to the hospital for a week just to do their transplant workup. So get your CAT scan, get your bone marrow biopsy, all those things. That was your week in the hospital. The actual transplant was 6-8 weeks in the hospital in isolation. And as I'll show you later, this has really changed incredibly over that span of time. So let's talk about some of the realities and myths that are abounding out there in terms of transplant. Some of it is this idea that transplant is too toxic. Second part is only young patients can get a transplant. And the third part is there a benefit now that we have all these other drugs for transplant? The reality is certainly in terms of safety. In fact, we are now able to say that transplant, the risks are about the same as the chemotherapy that you get from your initial diagnosis. So, we do more and more transplants. We fortunately have gotten a lot better and refined our techniques on that. Second thing is age limits. So when I started at City of Hope, I was in my 20s, and we would not transplant anyone over the age of 60. And when you're 20, 60 looks really old. I'm not going to say, my age now, but let's put it this way. 60 does not look that old. And in fact, there is no upper age limit for us in terms of absolute age. We really look at physiologic age now and put that into the context of what we call comorbidity, so other kind of chronic conditions that go along as you get older, and use all of that together in terms of deciding, is transplant an appropriate option for patients? And so, we really don't have a set upper age limit anymore at all, both in terms of transplants using your own stem cells as well as transplants using donor cells. But as I'll show you, donor transplants do have more risk, so we tend to be a little bit more cautious in terms of the age limits that we do think about it in that setting. The third part of this is really, as transplanters, we think that using all these new drugs just serve to make transplant better and improve outcomes down the road and lengthen remissions for patients. So you can see here, survival is getting better and better for patients with transplant as things go, both because we're learning how to do it better, but also because of these other new myeloma drugs as they come on the scene. The other thing, and this is what I alluded to earlier, so you can see the age range is now starting to change with, the group, certainly that over 70 group went from pretty much non-existent to now, still a minority of patients, but certainly there. And the majority of patients, certainly in the myeloma setting, are between the ages of 60 and 70. And just to put it in context, we do about 7,000 transplants a year in the United States for myeloma. It's the leading indication for autologous transplant. But having said that, the reality is only 30% of patients who are eligible for transplant are referred to transplant centers. And so, even if you're not interested in a transplant, and that's certainly a valid decision and option, it's really a good thing to have at least that discussion and consult as part of your sort of treatment as it goes along, so that you've really explored every avenue or option available. So this is the trial, I think, that really generated the most interest among many of us in both the transplant community as well as those who are not as pro-transplant in the setting of novel drugs. And really it tried to answer the question with the most common regimens that we use, RVD, which many of you are probably familiar with, is there a benefit to doing a transplant early? And I tend to think of this trial less as a transplant versus no transplant trial, more as a early versus late transplant. So you can see everyone in this trial, and this was a huge trial. It was the IFM Dana-Farber trial that patients got RVD. Everyone had stem cells collected, so that's an important point. One group went on to get transplant, so that's the group on the right-hand side, the melphalan, followed by RVD, and then the French arm of this trial stayed on lenalidomide maintenance for 12 months. The other arm continued on RVD and got a total of 8 cycles, followed by lenalidomide maintenance for 12 months. Now, I should add, there is a U.S. arm of this trial that recently just completed accrual where it's a little bit different because the lenalidomide is going to be continued indefinitely and much more in keeping with sort of the U.S. practice. But really just focusing on this trial for now and remembering this caveat about the 12 months of maintenance, what we saw is, if you remember when I talked to you about MRD, remember MRD, I said you'll see it later, and you do see it here, that the patients who had an early transplant had a higher rate of MRD. And certainly they also had a improved progression-free survival, so their remissions lasted longer. Now, the conundrum for us is this. So this is overall survival, and you can see the curves are identical. The patients who had an early transplant versus those who just chose to delay their transplant, the ultimate survival was the same. Now, having said that, ultimately 80% of patients who didn't have a transplant early ended up having a transplant in that late transplant group. So for those of us as transplanters, it became more a question of early versus late, and both those options being valid options and having those sort of discussions with our patients in terms of timing of transplant. Have you had a transplant? No, but I will soon. No, I'm considering one. No, my doctor tells me I'm not a candidate, or yes. Yes, so what? So a little bit over half of people here have already had a transplant. So you're, I think, very familiar with some of the things I'm going to tell you here, and about a quarter are considering it, so hopefully some of the things I'm going to tell you will help you sort of before you get ready for it, or even before you consult for it, in terms of being a little bit familiar with some of the process and terms. So this is just the general overview. Induction therapy, so that's the treatment you're getting before the transplant, in terms of usually with your local doctors. Stem cell mobilization is our fancy way of saying how we collect stem cells. Those stem cells are frozen, and then the actual transplant's on the right-hand side there with the high-dose chemotherapy, and infusion of those stem cells. So how does it sort out? Well, again, as I mentioned earlier when I showed you Dr. Thomas's picture, the field's changed a lot. So when we started, we used to do it the way on the right there. We would take patients to the operating room, give them general anesthesia, and you remember that bone marrow biopsy? Well, we would go in 50 times approximately on each side and collect a liter of bone marrow. So, you can imagine that's not an attractive selling point for patients in terms of an option. And the other thing is actually bone marrow cells take a lot longer to engraft. So the period when your counts are low is much longer, setting you up for a higher risk of infections. So you fast forward 10, 20 years, and we were able to move to something called leukapheresis, which is where we're able to give shots, usually Neupogen shots, to stimulate the bone marrow, and those stem cells are then kicked out into the bloodstream, and we do a procedure where patients are hooked up to a machine, their peripheral blood is spun through this machine, it's a big centrifuge basically, and we spin off their stem cells and freeze those in something called DMSO, which for those of you who are horse racing fans, that's the stuff you use a lot on horses, so it has a funny smell to it. The other thing, as I told you, things have changed a lot, certainly in City of Hope from when we first started doing transplants. We used to do, patients would be in isolation, we'd gown, glove, hair nets, the whole 9 yards before going in the room. as thinking evolved, we learned a couple things. Number one, most of the infections, certainly in the setting of autologous, using your own stem cells that patients get, tend to be from their own bodies, usually from your GI tract or your mouth flora. So, because those are the areas in your body that really tend to have a lot of bacteria. Second thing is keeping people in isolation in a tiny room it is also just not good for the rest of you, right? It's sort of like sitting in that economy class seat for 8 hours, right? You start to lose muscle mass. Your lungs, you're not taking big deep breaths, you're not walking around, and certainly psychologically too, it's not easy to be in that room and everyone else leaving that room. And so, as again, our thinking evolved, and we realized that certainly moving transplant to the outpatient setting for myeloma was something that would be good for patients. And so we've really moved to the outpatient setting. Patients stay in the apartments on campus and come in every day to our day hospital. It gives them a lot more control over their own lives. No one's waking them up at midnight to weigh them, do their vital signs, those kind of things. And again, even just walking back and forth to the day hospital, they get much more exercise than they used to sitting in the hospital bed all day. Now, in regards to the high-dose melphalan chemotherapy, so melphalan is pretty much the standard regimen that we use for myeloma transplants. It is sort of old-fashioned chemotherapy, so it does have the side effects you associate with old-fashioned chemotherapy. So nausea, fortunately, again, that tends to be fairly manageable in this day and age, with all the better anti-nausea drugs we have. Chemotherapy does affect cells that divide rapidly, though, and so that's why it can cause diarrhea, because it's affecting the cells in the GI tract, in the intestines. And unfortunately, it does make you lose your hair, because, again, it's affecting your hair follicles. Sometimes, usually not a huge part of it, but it can cause mucositis or mouth sores, again, because affecting the cells lining your mouth. And the thing that inevitably happens to everyone is the thing on the right, that it will drop the blood counts down to zero. So, and this is probably the lowest anyone's blood counts have been since the start of their chemotherapy. Fortunately, I said, we reinfuse those stem cells, the blood counts recover. It takes about 10 days for those counts to recover. So patients are with us for about a span of 2 weeks, from the start of giving the chemotherapy, reinfusing the stem cells, and then waiting for the blood counts to recover. Now, having said that, when patients go home, it's still not, your blood counts tend to come back before the rest of your body. And so, patients will be noticeable for how fatigued they are. And, a lot of this is sort of common sense. Everything your mother told you is kind of true, right? So eat well, exercise, wash your hands, prevent infection, avoid, people who are sick. And so all those things in terms of supportive care after the transplant are also equally important. After that, we have to wait a little while. So we wait about 6-8 weeks and then reassess what are the effects of the transplant in terms of your myeloma. Now, in reality, it can actually take even longer than up to 3 months to see the full benefit of the transplant in regards to your myeloma. Generally, though, as I said, we reevaluate about 6 to 8 weeks, and then we move on to this concept of continued therapy or maintenance or consolidation therapy. And this is a huge area both of research and controversy in the myeloma setting. And I say controversy because we certainly have many trials now suggesting that maintenance improves remissions, and several trials suggesting maintenance can improve survival. What we don't know yet is, number one, what's the best drug combination for maintenance? And number two, how long do we need to keep patients on maintenance? So some of the future trials you're going to see are going to try and address those questions. And so that's why the half of you in this room who've already had a transplant, you may find that some of you are on different maintenance regimens, different schedules, those kind of things. And that's, as I said, because of these unknowns in that part of the field. And I'll just spend a few seconds, because this is something that we did for many, many years, in terms of the same idea of 1 is good, maybe 2 is better, so doing a second transplant. And certainly when we collect stem cells, we collect enough stem cells for 2 transplants. And earlier studies, and there's a whole list of them here, and most of those were European studies, suggested that certain subgroups of patients could benefit from a second transplant in terms of getting longer remissions. Now, having said that, on the left it says BMT CTN 0702. Actually, I need to update that. because that trial, which just completed and read out last year, in fact, did not show a benefit to doing 2 transplants. However, we're stuck with the fact that another European trial, which read out at the same time, did show a benefit. So, this matter still remains, I think, a great debate among myeloma doctors. Generally, though, in the United States, most centers outside of a clinical trial don't routinely do tandem or 2 transplants, sequentially. Most centers, though, will certainly try and collect enough for 2 transplants so that they reserve extra stem cells down the road if patients relapse, to have a discussion about doing a second transplant at that time. And then my last few slides really just about this idea of doing a transplant from a donor. And again, we've tried to address this in many, many large trials. And this was another large US trial where patients who had myeloma, if they had a sibling donor who matched, they were assigned to the arm with a sibling donor. If they didn't have a sibling donor, they went on to a standard autologous transplant. And then we followed these patients and tried to see, was getting that new immune system from the donor better in regards to controlling the myeloma. And indeed, patients who got the transplant from the donor had lower risks of relapse from their myeloma. But on the other hand, we saw these kind of complications. So this is something called graft versus host disease, where that new immune system can cause reactions in the patient's body. And so unfortunately, the survival was the same because patients did get graft versus host disease when they got that new immune system. About a third of patients, in fact, did. So the risks and side effects from this, ultimately survival was the same in both arms. So allogeneic transplant or transplant from a donor is not a routine, again, outside of a clinical trial, but it is something that we do consider for select groups of patients. For example, I have a 24-year-old patient right now with myeloma, and so she is someone where we are considering doing an allogeneic transplant. So this kind of just sums it up, that the mortality rate from doing a transplant with a donor is higher really because of this graft versus host disease effect. On the other hand, as I said, the relapse rate is lower because of this immune effect. So the real question becomes, how do you get this immune effect without doing a transplant from a donor? And you're going to hear a lot more about that from my colleagues this afternoon in terms of immunotherapy. But really just to show you sort of where the field is going and what we're thinking about. So these are all the trials kind of asking that question I told you earlier in regards to still trying to answer, what's the best maintenance regimen? How long do you keep those maintenance regimens going? What combination of drugs, et cetera? And this is just to give you a flavor of all the immune therapy options that we're starting to explore after the transplant. So that includes certainly vaccine therapy. There's been a lot of interest in CAR T cells. Right now, they're really being done in the setting of relapsed myeloma, which you'll hear about, but we've really had a big interest in moving those earlier and maybe doing them for certain selected patients after a transplant, for example, and various other sort of immunotherapy modulation kind of things, manipulating the immune system after an autologous transplant. So these are the questions that I'd recommend, you ask your doctor, among other things. I think we touched upon some of them in terms of, at least for the City of Hope prep. And I would say it's probably about the same for most centers in terms of the 2-week periods. Some centers differ. Some centers do it inpatient versus outpatient. How many transplants do you do? Certainly the more you do, probably the better you become at it. And then that's what we touched upon in regards to deciding if you are or are not a candidate for a transplant. And then coping and support. And, I think you've heard just incredibly about that. And I really don't have much to add in terms of caregivers and how important they are. And certainly for our day hospital, they're a pillar of our day hospital because we couldn't do it without them in terms of having these transplants as an outpatient. And again, just in summary, autologous transplant still remains a standard of care for myeloma. We're looking to try and make it better in regards to improving and lengthening remissions further and further. And allogeneic transplant, a transplant from a donor, is still under study, and there's still large trials going on in the United States trying to also make that safer and trying to really figure out who is the best patient population. But I really think the future is really going to be a combination of immune therapy with autologous stem cell transplantation. Thank you.
Thank you very much, Amrita. We're going to lose you, I believe, and so we have to ask you all the questions now, and there's a lot of questions about stem cells. And a lot have to do with the timing of collection. And so a patient in their 30s, should they collect the stem cells now for some possible future transplant? For a second transplant, are 13-year-old stem cells still good? Should I collect enough for 3 stem cell transplants?
So a lot of great questions. So in terms of should you collect early, I would say yes because of 2 things. Number one is that we do know certain drugs, if you give them for prolonged periods of time, it becomes more difficult to collect stem cells. And there's some older data looking at, for example, Revlimid, and long-term exposure to Revlimid makes it harder to collect stem cells. So certainly trying to collect stem cells earlier in the course of treatment, even if you're not going to go to transplant immediately or early, would be a good option to explore. Now, having said that, the challenge is not all insurance companies will allow that, and it seems to be just very not sort of across the board different, and so that's one issue for patients. The other thing is in regards to, obviously the centers keep those stem cells. We keep them indefinitely. And so, in fact, we have to sign every year. We keep buying more and more freezers because of that. And so in terms of 13-year-old stem cells, and it's kind of like stuff in my freezer, we do use old stem cells. And I have the longest one I've used is 12 years old. I don't know if Leaf's had anything.
Yeah, about that.
So, and we do check what we call viability, or how good they are before we infuse them. So that is an important point too. And in fact, I would say that people who've had that long remissions from their initial transplant, those are the patients that we are even more enthused about doing a second transplant, because we think that they're the ones that are going to have the best outcomes from doing a second transplant. In terms of collecting enough for 3, certainly certain centers do that. I mean, we don't aim to do it in terms of our cell dose, but certainly if we have enough, our general target is 2. Number one, just because you can't keep leukapheresing or keeping someone on that machine day in, day out for to get enough of those cells. But generally our target is for 2. And again, that may differ center to center. So thank you.
Here's an interesting question. What about a syngeneic transplant from an identical twin?
So I would say yes. We certainly do those. We do. Obviously, just finding identical twins. So we've done at City of Hope. We've done about 6 of those, and certainly, if we had the choice between a syngeneic donor or an autologous donor, our preference has been a syngeneic donor because even old studies, again, these are really old, because again, finding identical twins is not that common, suggests that still, even with a syngeneic donor, the relapse rate has been lower than using your own stem cells.
And why would transplant be the only option offered to a patient?
Leaf's giving me all the hard questions before I run out of. I don't know that I would say think of it, at least when patients come to us, I don't think of it as the only option. I think of it as these are your array of options, but why not keep all the options open and available to you? And certainly, obviously I believe in transplant as what I've shown you, getting the deepest remissions. And right now I still think it has the track record for the longest remissions. And the fact that we can do it, more safely, speaks to why it is sort of a leading option for us.
Last question. Do you filter out or kill the cancer cells that might contaminate the harvest?
So another great question, and we've done trials looking at that. We've done something called CD34 selection, which is really, CD34 is on stem cells, just taking out just the stem cells. What we found is a couple things. Number one, there's something in that mix of when you do the leukapheresis that you need. So when it's a lot of patients, in fact, didn't engraft as well. They got a lot of strange infections, a lot of viral infections, And in fact, the relapse rate was no different. So we think that it's really most of the times that patients relapse, it's not from the stem cells we're reinfusing, but it's from residual myeloma in their own body, and hence this idea of sort of this maintenance therapy, consolidation therapy, or treatments after the transplant. So,
Thank you,
thank
Amita.
you.